Society, and I'll be discussing with you how to screen and diagnose osteoporosis. Then a second presentation will be done by Dr. Thamer Al-Isa, who is the chief in the Division of Endocrinology, Diabetes and Metabolism at Jabir Al-Ahmed Hospital, and he'll be discussing the use of non-pharmacological and anabolic therapy. That will be followed by Dr. Shayma Al-Anizi, who is a consultant in internal medicine and endocrinology in Al-Adan Hospital, and she will cover the treatment with the anti-resorptive therapy. Finally, Dr. Fatma Putayban, a consultant of medicine and rheumatology in Jabir Al-Ahmed Hospital, will give you a brief summary of the new management of steroid-induced osteoporosis. Hopefully, if you find anything that you need to have more questions, you drop it in the Q&A box, and at the end, the panel of the 4 speakers will be ready to answer all your queries and questions. So without any further delay, let me start with the first presentation dedicated for screening and diagnosis of osteoporosis. And I think this part is important for all doctors in whatever subspecialty they are. So all of them, any caretaker should be a doctor who's looking after a patient, should be able to screen and diagnose osteoporosis. Many of the doctors still believe that or holding to the old WHO diagnosis of osteoporosis based on the T-score. So with a BMD done, the T-score, which is below 2.5, is osteoporosis. And when there is a fracture, this is established osteoporosis. Between -2.5 and -1, this is osteopenia. And above -1 is normal. However, with time, we learned that BMD is not the independent, it is an independent predictor of fracture, but it's not the only one. So just taking into account the BMD will be missing more than half the fractures in females because they can happen in osteopenia and even in normal T-score. And surprisingly, 1/5 of the men fracture when their T-score is in the osteoporotic range. Many, they will fracture at a higher T-score. So many other clinical risk factors has been identified and gathered in a tool to predict the fracture risk, and it's called WHO Fracture Risk Assessment, FRAX, and it can, adding all the clinical risk factors, will predict the 10 years probability of fracture. And this tool takes into account the country of the patient. BMD is optional, you have it or without it, you can still get a value for the prediction. Age, gender, low body mass, as the height and weight are added to this tool. And then there are some dichotomous questions, the answer for which is either yes or no, any previous fragility fracture, any parental history of hip fracture, glucocorticoid treatment, current smoking, alcohol intake, rheumatoid arthritis, and other secondary causes of osteoporosis. FRAX has become the standard of treatment currently, and more than 70 countries, they are relying on FRAX in assessing their osteoporotic patients. And most of the recent guidelines, up to more than 100, are FRAX dependent. Okay. Let me give you an example. If I take an index case of a female age 65 with a T-score of -2.5, who will be previously treated in all countries because she's in the osteoporotic range with an average BMI. What is her calculated risk of fracture? Because all what we aim at is to reduce the risk of fracture. If this lady is in Denmark, her risk of fracture can be up to 70%, so very high risk. Whereas if she is in one of these countries, Philippines, Tunisia, or China, she will have a very low risk of fracture. So it is unfair really to treat this group of patients who have a low risk of fracture when they have the T-score of -5. But we need to calculate their risk of fracture and act accordingly and not by the T-score. Not only the country matters, but also the ethnic group within a country. If we look to the Caucasian in USA and compare them to the Black population in USA, there is a marked change in the risk of major fracture using the FRAX. Luckily, we managed to create a Kuwait model based on our data in Kuwait. So that will be a better representative of our population, and we can act according to our own population standards. So Kuwait will fit into like in the middle range here, not the very low and not the very high risk. And that is based on the age standardized annual incidence of hip fracture according to the country. So the country coded in red, these countries, they do have a higher incidence of hip fracture. Those in green are low risk of hip fracture, and Kuwait is in the middle range over here. To use the FRAX, you have to enter to their site and click on the calculation tool, choose your geographical area, Middle East and Africa. And these are the countries in that region who have their own models. Recently added to this is Saudi Arabia and Qatar. This is how you enter the data in your FRAX, and you can still get a FRAX score even if you don't have a BMD. But adding the BMD will make it more accurate and higher predictive value. And when you come to add the BMD, you go to the femur neck BMD. It's better that you enter the value in gram per square meter compared to T-score. So try to put the actual BMD value. You have to choose the machine, and that you can easily get it from the report you have. And once you enter the name of the machine and the actual BMD value, you will have the calculation for the major osteoporotic fracture. This graph, though, seems a bit complicated, but it is the core of the guidelines. So understanding this graph will be really crucial for you to be able to implement it in your clinical practice. And with that, we need to learn three new terminologies. They are not really new, these are the same in 2018. Lower assessment threshold, intervention threshold, and upper assessment threshold. What is lower assessment threshold? As you know, FRAX is also age dependent. So the higher the age, the higher the FRAX score. And here is the 10-year probability of having a major osteoporotic fracture. So this line representing the lower assessment threshold is the FRAX score for patients at different age groups who have no clinical risk factors. So their risk of fracture is really quite low. And that determined this line, lower assessment threshold, this line over here. Then we have this line on top of that, which is called intervention threshold. And that's derived from fracturing ladies at different age group who have a previous fracture and no other clinical risk factors. So that line is a patient who had a fracture. So naturally, any patient who lies above it, any score above it, means this patient is at risk of fracture. And then we have this line called the upper assessment threshold, which is the same as the intervention threshold multiplied by 1.2, that is adding 20% risk of fracture. Here is the lower assessment threshold, here is the upper assessment threshold, and here is the intervention threshold. So how we implement this table, you get a 60-year-old patient here who comes to your clinic without a BMD. And you do the FRAX, answer all the questions except for the BMD, and you get a score. If the score is less than 3.1, then he is in this area, he's a low risk. If the score is higher than 7.8, it is here, so it is a very high risk. If it is in between these two numbers, then you really need a BMD to determine the risk of fracture. Once the patient is sent to have a BMD and he comes back to you, you refrax him, but at that time you add the value of the femur neck BMD, and you compare the FRAX score that you get it with the BMD to the intervention threshold. And this is how this graph looks like. You have to assess your patient for the fracture risk, not for the T-score, not for osteoporosis, osteopenia. You are talking now about fracture risk. So any postmenopausal women or men above the age of 50, first question you have to ask them, did you ever have a fragility fracture? If they did have a spinal fracture or a hip fracture or two other fractures which are fragility fracture, remember that skull hands and feet are not considered fragility fracture. So we're talking about any other fractures that happen with low trauma, but not in this area. If they have one spine or one hip or two other, then these patients are very high risk patients and can be sent to treatment, and you need to treat them with anabolic agents. Whether you do them a BMD, a DEXA scan or not, it's up to you. Whether you do it or you don't do it, you are still right. In fact, we like to do it so that we have objective evidence of the effect of our treatments once we started. But if your patient did not have any history of fragility fracture, or he had one non-vertebral fracture, so a humerus, a Colles fracture, or anywhere else, then in that time, and he doesn't have a BMD, you apply the FRAX. So in the first visit, without BMD, you apply the FRAX. If the value of the FRAX score lies below this line, then it is a low risk of fracture, and you need to reassess the patient with FRAX in 5 years, or unless the patient develop another clinical condition that mandate osteoporosis screening. And again, if without a BMD, that's T-score, the FRAX score comes in this red region, which is above the upper assessment threshold, that is by definition a very high risk patient. You can treat with anabolic with or without a DEXA scan. Then where are the patients we need to do for them a DEXA scan? Those who lies in the orange one, the middle. So if it is between the two assessment threshold, we cannot determine the risk, but we need to perform a DEXA scan. Again, after the DEXA scan, we need to repeat to calculate the FRAX score and compare it to the intervention threshold. If it is below the intervention threshold, it's a low risk, and we need to reassess the patient in 3 years. If it is after with the BMD above the upper assessment threshold, above the upper assessment threshold, then this is again a very high risk patient. And if it is between these intervention threshold and upper assessment threshold, these are the patients who are at high risk but not very high risk. And those patients are the one we need to treat with anti-resorptive. Of course, FRAX is much better than relying only on BMD, but it is not the 100% ideal tool. There are some limitations to that, such as the age limitation between 40 to 90. It's not applied to the premenopausal women. It also not applied to treated patients, so only untreated patients. BMD input is only for the femur neck, so it's only for the hip region. Dose effect is not considered for the fracture, how many, smoking amount, glucocorticoid dose, alcohol, is just yes or no. It's limited to certain countries and ethnic groups. And there are other risk factors that are not considered, such as other medication other than glucocorticoid, risk of falling, and rate of bone loss. For that reason, we have to try to improve our risk reduction, and this we added in this new guidelines, and we called it risk enhancers. Why? Because they enhance the predictive value of the FRAX score. And what are they? It's the percentage of adjustment we make for the major osteoporotic fracture risk based on clinical evaluation in the history and DEXA scan. Lumbar spine discordance. So if the lumbar spine is lower in the T-score, say for example, the femur neck is -2, but the lumbar spine is -4. So there is a discordance, the lumbar spine being worse. So for each standard deviation, the risk is increased by 10%. So to adjust or to enhance, for each standard deviation, we multiply by the score of the FRAX calculated by FRAX, and 1, which is the 100%, and 0.1 is the 110% risk created by the discordance. Type 2 diabetes is tricky because the patients with type 2 diabetes tend to have a high BMD, yet they have a higher risk of fracture because of the deterioration in the microarchitecture of the bone. And it was found and compared to the rheumatoid arthritis and found that the risk is about the same. So when you're FRAXing a patient with type 2 diabetes, you can tick rheumatoid arthritis as yes, or you can use a femur neck BMD, and rather than putting the actual value in the BMD, you made it worse by half a standard deviation. to accommodate for the microarchitecture deterioration, or increase the age by 10 years. Patients who are on androgen deprivation therapy and or others who are breast cancer, prostate cancer, again, they have the same risk as rheumatoid arthritis. So you can use the same trick of using rheumatoid arthritis as a surrogate. For the glucocorticoid dose, when we tick yes for glucocorticoid, we're tackling patients who are on the medium dose, 2.5 to 7.5. If they are on a higher dose than 7.5, that will increase their risk by 15%. So you multiply the score by 1.15. However, if the dose is less than 2.5, then the risk is about 80% of the medium dose. So you multiply it by 0.8, and it's like a minus 20% risk. Just two quick examples to make picture clear for you. This is a lady, 60-year-old, who has a T-score in the spine -3, in the femur neck -2, and the measured fracture score was 6.2%. But she had a 1 standard deviation disorders, so we multiplied her score by 1.1, and her actual or enhanced fracture score came up to be 6.8. How about the diabetes? For diabetes type 1, it usually results in a lower BMD. So type 1 diabetes acts by lowering the BMD. Hence, we just take secondary osteoporosis as yes. However, for type 2 diabetes, we can take rheumatoid arthritis as yes. Or, for example, if the patient have both rheumatoid and diabetes, we can revert to other models like select BMD. Instead of putting -2.1, we can make it lower by 0.5, half a standard deviation, and it will be -2.6. We enter the value of -2.6, or we increase the age of 10 years. One of the new concepts that has been added recently is the recent fracture. So the recent fracture carry much higher risk than an old fracture. And it was noted after a recent fracture, immediately in the first 2 years after the fracture, that can increase the hazard ratio for developing a fracture. And that declines with time until after 4 or 6 years, it comes back to the same risk like having a previous fracture. But a recent fracture have something called imminent, that is can happen quite soon. If you have a recent fracture, the risk of fracture will be high in the first 2 years and subside. Whereas if you have a patient with a very high risk, he will have a risk which is the same all through. And this model has been established by Keynes et al. And published in 2020. And it's for a previous vertebral fracture or a hip fracture or a humerus or a forearm. These are the models that has been studied. And in our Kuwait guidelines, we decided to ignore the vertebra and the hip enhancers, because any patient with a recent vertebra or a recent hip is by definition a very high risk. So we don't need really to go around the fracs. But if he has a recent humerus, for example, and so if the patient is younger, like 40 plus, it carries a risk of 4.39. And the older they get, that reduce the enhancer correcting factor. And in our guidelines, we have included this as a recent humerus. So if you have, for example, a 60-year-old patient who have a recent humerus, after calculating the risk of fracture, you have to multiply it for 1.5, because that will account for the recent humerus. If that fracture has occurred more than 2 years ago, you don't have really to go for this recent fracture enhancers. So this is how our guidelines look. This is the page I have already explained to you. We have something else also to increase our precision and our predictive value for the assessment, which is called the vertebral fracture assessment. It's been noted or known that 50% of the fragility fractures occur in the spine. Yet only 30% come to clinical attention. Many of them are silent and pass unnoticed. So this vertebral fracture assessment, after the patient does his DEXA scan, they just put them in the lateral position, and they have this nice view of all the vertebrae, thoracic and lumbar, and they can calculate the anterior and posterior and the mid diameters, and can tell if that is a crushed fracture or a wedge fracture or a biconcavity. So who are the patients in whom we need this? Any patient, a woman aged more than 70 or a man aged more than 80, if they are more than 50 but has one of these risk factors, which is a low trauma fracture. So if she had fractured previously, you have to ask for a VFA. If she has a historic height loss of more of 4 centimeters or more, or while following her up, she had a prospective 2 centimeter height loss, or patients who are on recent or ongoing long-term glucocorticoid, because glucocorticoid has a strong predilection for worsening the lumbar spine. And this just to emphasize on the core of the guidelines, and below this are no treatment, above them this is above treatment. But I want to emphasize on one thing which there has been a lot of concern about, which are the very high risk patient. And I will just repeat, because these are very important. We should recognize them and refer them to the hospital as soon as possible. Any patient with a prior vertebral fracture, even if that was only by VFA, if the patient did not give history before, if you find a fracture in the vertebra, refer him, because he's a very high risk patient. Prior hip fracture, more than 2 fragility fracture, or if they are already an osteoporotic fracture but they fracture, or if you enhance or adjust your fracture score and it came up above these numbers, above the upper assessment threshold, and you have enhanced it for a lumbar spine discordance, type 2 diabetes, glucocorticoid dose, androgen deprivation therapy, or a recent fracture. I chose not to talk about TBS since this modality is not available in Kuwait yet. And if the patient is also having frequent falls and frail elderly patient, you should have some increased concern about them. I've covered this page and this one, and that would cover the diagnosis of osteoporosis. And this is the complete guidelines. So now we will move to Dr. Thamer El-Isa, who will talk about what is the initial assessment and how to start non-pharmacological drugs and the anabolic. And then Dr. Shaima will cover this part, which is the anti-resorptive. And finally, Dr. Fatma will give you a summary of how the glucocorticoid induced osteoporosis is managed. Thank you very much for your attention, and thank you. And we'll move now to Dr. Thamer El-Isa.
Thank you all so much for being with us in this webinar talking about latest changes and updates in the guidelines for management of osteoporosis in Kuwait. Welcome for this evening. Thank you for our sponsors. Also, thank you for our chairperson and speaker, Dr. Nadia. So my task today is talking to you about treatment of osteoporosis, specifically talking in the first initial part of this lecture is about non-pharmacological treatments and anabolic therapy. These are my disclosures. Talking first about non-pharmacological therapy, for the part of this investigations and the blood test and the required test for evaluation for patient osteoporosis, I will leave it to the end with Dr. Fatma, since she's covering also the steroid-induced osteoporosis, and both share the same common pathway of how to investigate investigations required for osteoporosis. So here talking mainly about non-pharmacological treatments for osteoporosis. So in the updated guidelines, as you've seen in the previous talk with Dr. Nadia, the two main groups of therapies that are required for patients with osteoporosis are divided based on their risk of developing fractures. So you have patients with the very high risk of developing previous fractures, which are patients who previously had fragility fracture at the highest risk in terms of the frax prediction. And you have the other patients who have also elevated risk for developing fractures. And any of those situations of risk of fractures that require therapy, the non-pharmacological part consists of several things. One is cessation of smoking, as we believe that smoking has a negative impact on bone health, increases bone resorption, And quitting smoking and limiting it as much as possible could have a beneficial effect on bone health. Alcohol is also another factor which can increase bone resorption, and also excessive alcohol intake is also associated with malnutrition, and that also could affect the health status of the body, and including the bone. And also alcoholism as an addictive substance and an addiction condition can lead to related to neuropathy and other medical condition can increase the risk of falling and then fractures also. We try to, as much as possible, limit the amount of coffee intake to less than 3 cups a day. Caffeine is also an important nutrient, which we think it has a beneficial effect on health, but excessive caffeine intake could also have negative impact on bone health. The excessive caffeine could have increase in the bone resorption, and also that could have an effect on reducing bone density and also bone quality. We try to, as much as possible, initiate weight-bearing exercises because we believe weight-bearing could have a beneficial effect on bone health. With 30 minutes per day activity, we'll talk about in the next few slides. That would including walking, jogging, dancing. Strength and resistance exercise is another type of training that we would like to have these patients to have. We also advocate the balance training, which is helpful to reduce fractures, reduce falls, and then eventually fractures. And also we promote stretching exercises. And stretching exercises are helpful to maintain the muscle activity, reduce the injuries that could happen in patients who on frequent daily activity levels or exercise. Stretching could help improve the muscle action and then reducing any possibility for injury of the muscles. We want also make sure to take any measures that can reduce the risk of falling, including physical activity, physical therapy to improve the mobility and reduce the risk of falling. The pharmacological treatment, I'm just here mentioning a few parts of it that is not really drug related here in the slides, which are treating vitamin D deficiency, because we believe vitamin D deficiency is a negative impact also on bone health, increases the chance for developing osteoporosis and also fractures. So improving vitamin D levels could be helpful in that part. So if we find a vitamin D deficiency, we want to treat it and maintain it. So not only treat a deficiency, but also maintain it. The maintenance doses could be somewhere between 1,000 to 2,000 a day of vitamin D3. We prefer cholecalciferol, which is D3, which could have a better impact on improving vitamin D deficiency and also suppressing PTH. We want to achieve vitamin D level somewhere between 75 to 150 nanomoles. And we believe this is a therapeutic level to maintain quality and quality of the bone and also density of the bone. We want to maintain a calcium intake of somewhere around 1,000 to 1,200 milligrams per day of calcium. Preferably want to do that through diet. If not, then we can do that through supplements. 1-alpha or activated vitamin D should only be used in cases of chronic renal impairment and hypoparathyroidism. It should not be used to treat osteoporosis. It should not be used to treat vitamin D deficiency because it also has some of its risk factors and side effects related to hypercalcemia and hypercalciuria. So we want to keep it to treat these only medical conditions like CKD and hypoparathyroidism. To reduce the risk of falling, we want to improve lighting around the house, remove the loose rugs, add grab bars near the bathtub, specifically in the bathroom, where a lot of accident happens around the toilets and the stairways also. We want to have a formal home safety evaluation. There are several geriatric services available in Kuwait, and that could be helpful to evaluate the home safety. Physical therapy, as we mentioned, is important to improve core strength and balance, and that will reduce the falls. Eliminate medication that can affect the alertness and the balance of patients, especially if they are not really required or can be substituted with other therapies. And also we want to provide assistive devices for evaluation, also for training of patients. Calcium supplementation, as we mentioned, they are available in Kuwait. The two available types are either calcium carbonate, which is the vast majority of calcium that is available, especially in the Ministry of Health, is calcium carbonate, and also another type is the calcium citrate. Those two types of calcium are suitable for calcium as a maintenance and also substitution for patients who are not really having enough or having enough calcium intake by diet. The differences are as follows. Calcium carbonate can provide furthermore elemental calcium than calcium citrate. With 1,000 milligram of calcium carbonate, we can get about 400 milligrams of elemental calcium. That's almost double the amount of what could be delivered from the calcium citrate as elemental calcium of only 210 milligrams. Calcium citrate does not require to have an acidic or a low pH in the stomach. It actually can be used in patients with chlorhydria, patients on chronic PPIs or H2 blockers, or very old age that have less acidity in the stomach. These patients probably would do better if they are put on calcium citrate as a replacement of calcium instead of calcium carbonate. In calcium carbonate, patients should not be using PPIs as a therapy or as a joint therapy with their calcium intake. Calcium carbonate should be taken with food, so immediately after the meal they can take that, whilst calcium citrate suitable because they can take it with or even without food. The problem is that with the citrate is the least amount of calcium, elemental calcium, but that could be discussed with the patient based on the underlying medical condition would be the best choice to choose of calcium supplements. The single dose of a calcium supplement to be taken should not exceed more than 500 to 600 milligram per dose per tablet of calcium. That will help improve the calcium absorption through the gut. There are some meta-analysis developed and showed there is a modest increase in the development of MI and cardiovascular events in patients taking calcium without vitamin D supplementation. So we want to have mainly vitamin D supplementation, calcium by diet, and if not, then we can use these calcium supplements. These are natural sources of calcium. Dairy products are a major contributor for supplying calcium. Also fish, some packed and prepared diets like cereals, juices can be fortified types of diets to add calcium with it, nuts and some fruits. Vitamin D is also important to maintaining of healthy bones. Vitamin D3, which is cholecalciferol, the main source is from the sun on the skin. And the D2, which is ergocalciferol, and also cholecalciferol can be delivered by either supplements or by milk products. The total vitamin D, which is total 25 hydroxide vitamin D, which includes D2 and D3 as a measurement, and that's the one we use it for clinical diagnosis of vitamin D deficiency, insufficiency, or even normal level. This 25 hydroxide vitamin D gets hydrolyzed in the kidney by the renal 1-alpha hydroxylase into the very active form of vitamin D, which is 125 dihydroxy vitamin D to produce its effect. And this also goes into ineffective or inactive products with further hydrolyzation within the extrarenal area, and also to cause inhibition of the effect and then balance out the effect on the bone resorption. These are natural sources of vitamin D. Similarly, fish products, sun exposure is most importantly, dairy products, some other types of vegetables, especially mushrooms, some fortified meals also could be there. The most important thing we need to remember is that there isn't sufficient amount of vitamin D in diet. A lot of the vitamin D has to be taken from the sun. And because of some challenges in our area, a lot of times we use supplements to improve vitamin D levels. There are several recommendations came out on who to test vitamin D in terms of our population, less sun exposure, or who regularly cover up when outdoors. The patients required to be checked regularly for vitamin D deficiency. And you can add into that the patient who are at risk of developing osteoporosis, also they are at risk and need to be measured. And other people like dark skin individuals, patients on medications that affect vitamin D levels like anti-seizure therapies, GI medical condition like celiac disease, inflammatory bowel disease, bariatric surgeries, pregnancy and lactation, nursing home residents. In Kuwait, they mostly would be homebound. So these patients, unfortunately, these individuals, unfortunately, they don't get any much of a sun exposure and they need to have vitamin D checked regularly. Also obese and very overweight people. Vitamin D is a fat soluble, so it can be stored in fat cells. and they can cause a deficiency based on that. In terms of exercises, there are two main groups of exercise that we see that they're beneficial for bone health: weight-bearing exercises and muscle strengthening exercises. The weight-bearing exercises could be high impact. This can be done without weights, like jumping or high-impact aerobics, jogging and running, stair climbing, tennis and dancing. And they could be low impact, like elliptical training, low impact aerobics, stair step machines, and fast walking. We want to have these weight-bearing exercises to be done about 30 minutes on most days of the week. The other group is muscle strengthening exercises. And here we use the body itself in terms as a weight, or we can use weights to have more effect on muscles, like lifting weights, using elastic exercise bands, weight machines, lifting the body's own self. These are additional ways of strengthening the muscles. So muscle strengthening and weight bearing, like high impact and low impact, they're very important to be done for maintaining bone health. Muscle strengthening exercises, they can be done about 2 or 3 times per day per week, and about maybe 15 to 20 minutes. That would be optimal way of how to distribute the exercises patterns. What about anabolic therapy? So here we're talking about pharmacological treatments, and the first group we want to talk about is the anabolic treatments. Now, there are different classes of osteoporosis therapy. These different classes act on different areas and sites in the bone turnover and bone remodeling cycle. Especially if we're talking about the bone formation agents or the anabolic agents, the one available we use are 2 agents. First, they could be either mimicking or behaving as a parathyroid hormone. So they are parathyroid hormone analogs. And these parathyroid hormone analogs, they help to mature the osteoblast precursor. So they mature the osteoblast, make a bigger osteoblast that can actually lay down bone and build bone. The other way is to block the sclerostin by anti-sclerotin antibody. So sclerostin is in the green, is produced by the bone cells, and they actually start to inhibit the bone osteoblast cells. So by inhibiting this sclerostin by the antibody, anti-sclerotin antibody, you can have more availability of the osteoblast to do its function. So you can actually have more anabolic effect when you block this sclerostin. So you either can mimic parathyroid or you block sclerostin, so we can actually have a better effect on osteoblast action in terms of bone formation as an agent. So these anabolic agents, they increase bone mass to a greater degree than can be achieved with anti-resorptive therapies, because that's the main action, is to build bone mass. Anabolic agent could be a parathyroid hormone and the related peptide. The one we have is the PTH 134, which is teriparatide, or we can have sclerostin inhibitor, which is romosozumab, which we'll talk about in the next also slides. As you've seen in the general theme of the guidelines what we presented in this latest edition of the Kuwait Osteoporosis guidelines in terms of management, pharmacological therapy. Now, the division of the patients with osteoporosis, they can be either considered as a very high-risk individuals, and this has been explained in the previous talk, or very high-risk individuals. The ones with the very high-risk individuals, we believe that these patients are at the highest risk for developing further fracture, especially within the first 1 to 2 years when they have a high risk to develop imminent fractures, which is fractures that will happen very soon after the initial fracture. Or patients, their risk for fracture is very high, that the first fracture they could develop is actually near. So these patients, we consider them as the very high risk individuals, and we want to treat them with first as an anabolic therapy. So the anabolic therapy we have, there are 2 types, either the teriparatide, which is PTH based therapy, and these can be used as in daily injections, or romosozumab, which is anti-sclerotin antibody, and be given as a monthly injection. With teriparatide, there are certain contraindications because it's a PTH hormone itself. So the contraindication would be someone with hypercalcemia, someone with hyperparathyroidism that seems to be primary or still yet not confirmed to be what kind of a diagnosis. Skeletal malignancies, including primary and metastases, Patch's disease, and patient receiving radiation therapy and exposing the bone to radiation therapy. That's also a risk factor and should not be considered in these patients with teriparatide. Teriparatide should be treated for about 24 months as a maximum, and this can be done only once in a lifetime. Following the end of the therapy with teriparatide, all patients should be switched to anti-resorptive agents, which should be followed by the use of the initial anabolic therapy. Romosozumab, as we mentioned, anti-sclerotin antibody, can be given as a monthly injection. Contraindication is the recent myocardial infarction, cerebrovascular disease within the last 1 year, or patient having high risk for cardiovascular disease, and the risk of developing this condition outweighs the benefit of this therapy, and these patients should not be used on this therapy. We'll talk about this in the next few slides also. The duration of therapy for romosozumab is about 12 months. And then following the 12 months, similar to teriparatide, these patients need to be put on anti-resorptive therapy and continued on further on to maintain the bone density that they get during this anabolic agent time. Teriparatide is a form of PTH consistent of the first 34 amino acids, which is the bioactive portion. It stimulates osteoblastic activity, as we mentioned, and excreted in the urine with a very short half-life. It's given as a 20 microgram subcutaneously given daily. Injected could be in the thigh or in the abdomen, and is not really defined in patients with renal and hepatic disease, and can be used even in patients with advanced kidney disease. The effects is that with teriparatide, you can increase the BMD in the spine by about 9% and the hip by about 3% versus placebo over about 18 months. With that increase in bone density, there is a reduction in the risk of developing vertebral fracture by about 65%. We can see that the big success in reducing the vertebral fractures, and that's why teriparatide or anabolic therapy in general are very preferred in patients who do have spine fractures. Also, reduction of non-vertebral fractures by about 53%. The trials were so small to evaluate any effect on hip fractures, so we don't have a primary effect on hip fracture. There's only data analysis looking at the effect of hip fracture and showing in this data analysis there was a significant reduction, but it was not done as a primary objective of the trial. This is all based on 18 months of continuous therapy. Teriparatide also, as an anabolic agent, been chosen to be a priority of a first-line therapy in someone who does have a previous vertebral fracture compared to giving them anti-resorptive agent. This came also from this one of the trials that we tested this hypothesis, which is giving patient either teriparatide or rezidronate as an bisphosphonates in patients who already had previous vertebral fractures. Either 2 or more moderate fracture or more than 1 severe vertebral fracture with a T-score of -2.5 or lower. So these patients at very high risk of developing further fracture, so here we're doing secondary prevention rather than a primary prevention. So these patients were treated with teriparatide versus rezidronate for about 12 months. And within this 12 months, there is actually a significant reduction in the incidence of a new vertebral or further vertebral fracture by almost about 50%. When this trial was continued for about 24 months, it's almost similar or even a little bit better difference in terms of reduction of the new vertebral fracture. So the relative risk is about 0.4. So that's about 36% reduction, 63% reduction in the development of a new incidence of vertebral fracture. So significant reduction with this anabolic therapy. The side effect of teriparatide in human subjects, it was very mild and transient elevation in serum calcium that can be noticed because after all, it's a PTH. The mean increase in urine calcium of about 30 milligrams in 24 hours, but there was no statistical significant increase in hypercalciuria. There was leg cramps also noticed in some of the patients, and some dizziness also noticed in some of the patients, but they are minimal in terms of chance of developing. In rodents, there was increased incidence of osteosarcoma with high dose long-term exposure. And this actually comes in a black spot warning. So that's why one of the things that related to the limiting it to 24 hours is the lack of data, of safety data beyond that in human subject, because of the rats, of the effect that happens in rodents that did not really provide the ability to extend the therapy further to see the effect on humans. It's contraindicated, as we mentioned, increased risk of osteosarcoma, patients with Paget disease, for example, prior radiation to the skeleton, bone mets or primary to the primary malignancy of the bone, or hypercalcemia, or hyperparathyroidism, especially if it's primary or not diagnosed yet, of what type. Teriparatide has no safety data beyond 2 years, and it's used for a maximum of that period of time. And it's common practice to follow teriparatide with an anti-resorptive agent to maintain the BMD and prevent the bone loss. The other anabolic agents we have, which is relatively new in use, and also very new to be used in Kuwait, which is sclerostin inhibitor. There are several sclerostin inhibitors that have been developed. Romosozumab is the first one to be in the clinical field to be used. There is also one under development called bolosozumab. And there are some other given codes, but not yet in terms of in clinical practice or even in further development yet. Romosozumab is the only one that is available and has been used in Kuwait very recently. It's a monoclonal antibody that binds and inhibits the sclerostin, which is a bone-forming agent with a dual effect on bone. So this monoclonal antibody can increase bone formation and decrease bone resorption because its action on sclerostin. So these therapies, romosozumab, can have a dual action on increasing bone formation as an anabolic agent and causing also bone resorption as an anti-resorptive agent. But the main bulk of the main effect of this therapy is the bone formation action. This is given as subcutaneous injection monthly with an anabolic effect that wanes after 12 months. After the 12 months, there is no much of anabolic effect. That's why the therapy should be continued up to 12 months. So that's once every month, that's 12 doses and continue given 1 month apart. That's for 1 year of duration of therapy because of the anabolic effect. This is one of the first trials that tested romosozumab against other drugs. So this is in green, romosozumab tested versus teriparatide, which is the other anabolic we mentioned, as an open label trial, versus also alendronate as a bisphosphonate, also as an open label, and compared also to placebo. Now, these patients, they looked at percentage change from baseline in lumbar spine. Patients with romosozumab, they had the highest amount of lumbar spine increase. At the end of 12 months, the increase was about 11%, 11.3%, with teriparatide is somewhere around 7%, but much lower, about 4% with alendronate. Patients on the total hip increase in BMD with romosozumab, the gain has also increased significantly, especially around 6 months. With further gain until up to 12 months. The amount is much less than spine, 4.1% statistically significant comparing to baseline, or sorry, to placebo, and also comparing it to the alendronate and also teriparatide, which were less and significantly less than what romosozumab has shown in terms of density. This is looking at the median change in the bone turnover markers. As a bone formation bone turnover marker, which is BNB, there was initially an increase, which is caused by romosozumab as an anabolic agent, and then inhibition later on. At beyond 9 months, this bone formation agent was actually suppressed because of the effect of anti-resorptive effect of this therapy, as it's a dual effect, increase in bone resorption, increase in bone density or bone formation agent in the beginning, and then bone resorption later on. As you can see with teriparatide, because it's a continuous anabolic agent, you can see a high level of BN1B throughout the use of this therapy, while alendronate causing this suppression because of anti-resorptive agents. Beta CTX, which is a bone resorption agent, also you can see that there is a suppression with the romosozumab that continued on. So it's behaving here also as an anti-resorptive and continuous suppression of the CTX. Romosozumab, in terms of clinical action and the effect on fracture risk, this is the events of about 7,000 women with osteoporosis. They were randomized either to placebo or romosozumab. After 12 months of therapy, patient on romosozumab compared to placebo, they had the relative risk reduction of somewhere about 73% reduction in terms of risk of developing incidence of a new vertebral fracture. Because the limitation of the use of romosozumab, after the 12th month, patients receiving romosozumab, they were switched to receiving denosumab after that. And patient on placebo, after the 12 months ended, they were started on denosumab. Now, these two groups, both of them on denosumab, the differences between them were the background or what happened during the first year. In purple, they were receiving placebo before, and in green, they were receiving romosozumab before. You can see the same amount of reduction in terms of incidence of new vertebral fracture been maintained also as a second, after one additional year of giving both groups a denosumab therapy. Also, this therapy, even though improved the new vertebral fracture, but with romosozumab, there was no reduction in the non-vertebral fractures, which something also shared with the patients receiving the other anabolic agent, teriparatide, is not showing a clinical effect on the non-vertebral fractures. In terms of side effects or adverse events, including the adverse events, including instances of hyperostosis, cardiovascular events, osteoarthritis, and cancer. This was balanced in the FRAME study, which was done in women. There were more injection site reactions occurring in the Romo group, and there were one atypical femoral fracture and 2 cases of osteonecrosis of the jaw were observed in romosozumab group. That's possibly because of the anti-resorptive effect that also it contains, which we can see a lot in patients, not a lot, but rarely we can see that in anti-resorptive therapies. The other therapy, which was the ARCH trial. Now, the ARCH trial was different in patients who had previous vertebral fractures, and these patients were not given placebo. They were either given alendronate or given romosozumab, which is very similar to the trial that was done with Vero, teriparatide versus risindronate. So this is alendronate versus romosozumab for 12 months. Similarly, relative rate reduction was about 37% with romosozumab compared to alendronate. After 12 months, patients were all switched to alendronate. So patient initially on alendronate continued on it, and patient initially on Romo, they were switched on alendronate. And still, there was a significant difference, 48% relative risk reduction between the two groups. So here, this is again another proof that anabolic therapy is important to be used in patients at the highest risk of developing vertebral fracture. In this group of patients in the ARCH trial, there were patients already had previous fractures. In this trial, there was imbalance in the cardiovascular serious adverse events, 2.5% in the Romo versus 1.9% in the alendronate at 12 months in the ARCH trial. That imbalance in the cardiovascular events was not seen in the previous trial that I presented, which was the FRAME, which contained much larger group of the patients enrolled in the trial, compared to this, the ARCH trial, which is much smaller amount of patients. Should not be initiated for precautions, should not be initiated in patients who have had MI or stroke within the preceding year. And we want to consider whether the benefit outweighs the risk in patients with other cardiovascular risk factors. What about following up patients when they receive anabolic agents? So we want to monitor patients every 2 years when they are on anabolic agents by a DEXA scan. And we want to do comparing BMD, not T-score. When we see an increase in BMD, even stable BMD is not sufficient in patients receiving anabolic agents because we want to see an increase in BMD value. And the absence of fragility fracture, that means a treatment success. When we see a stable or a declining BMD with patients receiving anabolic agents or developing fracture, that's a concern, and we want to know why this happens. So with that, I end my presentation, and thank you so much for your attention.
Good evening, everybody, and thank you for attending our webinar today. And thanks for our sponsors. And thank you, Dr. Tamer and Dr. Nadio, for your informative presentation. I'm Dr. Shema Al-Anisi from Adan Hospital. I will be talking about anti-resorptive therapy for osteoporosis. I will be explaining this part of the guidelines. Containing anti-resorptive therapy will concentrate on alendronate, zoledronate, and denosumab. As you all know, the mechanism of action of available osteoporosis therapy, as was mentioned by Dr. Tamer, anabolic main treatment act by affecting the osteoblast, like teriparatide, or affecting both osteoclast and osteoblast. For the anti-resorptive therapy, it acts more on osteoclast. So we have bisphosphonates, including alendronate, ibandronate, and zoledronic acid. And we have rank ligand inhibitor, which is denosumab, and SERMs, which is raloxifene. We'll start by alendronate. It is an oral preparation given 70 milligram weekly. It reduces vertebral and non-vertebral and hip fracture. It is effective in male osteoporosis and in glucocorticoid-induced osteoporosis. It was approved in 1995. So alendronate, as you can see here, the effect of alendronate on risk of fracture in women with low bone density, but without a vertebral fracture. The study was published in 1998 in JAMA. It shows that, as you can see here, the dotted line is the placebo and the solid line is the alendronate. We can see here the mean change in bone mineral density, which is in femoral neck, total hip, and lumbar spine. As we can see, alendronate decreased clinical fracture by 36% and decreased the risk of radiographic fracture, vertebral fracture by 44%. Next, we'll talk about zoledronic acid, which is IV infusion, given 5 mg IV infusion once yearly. It also reduces vertebral and non-vertebral fracture, as well as hip fracture. It is effective in male osteoporosis and in glucocorticoid-induced osteoporosis. It was approved in 2005. Here we can see the Horizon study. Zoledronic acid, as you can see here in the orange line, and placebo with the blue line, and it showed the clinical fracture and mortality after a hip fracture. It is a randomized double-blind placebo-controlled study. 1,065 patients were assigned to receive yearly IV zoledronic acid, and 1,062 patients were assigned to receive placebo. The infusions were first administered within 90 days after surgical repair of a hip fracture. The rates of any new clinical fracture were 8.6 in zoledronic acid group, and it was 13.9 in placebo group, with a 35% risk reduction with the zoledronic acid group. And there was 28% mortality relative risk reduction in the zoledronic acid group. So for bisphosphonate, it binds to the bone and inhibit the osteoblast at the surface of the bone. As you can see here, the bisphosphonate in orange. It integrates into bone at the site of bone turnover. It affects and inhibit the mature osteoclast from taking its effect. What are the adverse effects of bisphosphonates? We have hypocalcemia. So you shouldn't give it for patients with low calcium. You need to treat that first. We have more with the oral preparation, gastrointestinal symptoms like abdominal pain, acid reflux, dyspepsia, esophageal ulcer, gastritis. Also, we can have renal toxicity, fever and flu-like symptoms, musculoskeletal pain and cramps, and inflammatory eye disease, iritis, more with the IV formula. And you can have also osteonecrosis of the jaw and atypical femoral fracture. Next, I will talk about denosumab, which is Prolia. It is giving 60 mg administered as single injection, subcutaneous injection every 6 months. It reduces the vertebral, non-vertebral, and hip fracture. It is effective in male osteoporosis and glucocorticoid-induced osteoporosis. It is a human monoclonal antibody against rank ligand. It was approved since 2010. It is safe in patients with chronic kidney disease, but the problem, it has a rapid offset effect. So you shouldn't stop it for 1 month more than total of 7 months. You should give it every 6 months, and you shouldn't stop it more than 1 month. Otherwise, you will have a rapid offset effect. So in case of stopping, you need to shift to another anti-resorptive or anabolic. As you can see here, we have the denosumab. It's the first class rank ligand inhibitor. The denosumab here in green, it inhibit and bind to rank ligand, which is in blue. So denosumab prevents rank ligand from binding to rank and the osteoclast precursor, so that inhibiting osteoclast formation, function, and survival. So it stopped the bone resorption process. So it's more bisphosphonate act on the mature osteoclast, whereas denosumab act on the maturation and stop it from maturation. As you can see here, the FREEDOM study, it is a randomized study, was published in New England Medical Journal 2009. 7,808 postmenopausal women aged between 60 and 90 with a lumbar spine or total hip BMD T-score between -2.5 to -4. And they were divided to two groups, denosumab and placebo, where the primary endpoints incidence of new vertebral fracture over 3 years, and secondary endpoint, the time to non-vertebral or hip fracture. As we can see here, placebo is in gray color and denosumab in green. So it's proven to significantly reduce fracture risk at the new vertebral and non-vertebral and hip. The BMD at the lumbar spine and total hip continue to increase after 10 years of denosumab. So it's a sustained increase in BMD over 10 years at a key sites of the body. As you can see here, the lumbar spine, the green line is denosumab, and we have the black line is the placebo, and then they cross over to denosumab. And here, as you can see, also it's better in the total hip. So for the ACE guidelines, recommended first-line agents for most patients requiring osteoporosis therapy, we talked about alendronate, zoledronic acid, and denosumab. And these were mentioned in Kuwait Osteoporosis guidelines for 2022. All of three are working on vertebral, non-vertebral, and hip fracture. So what are the adverse effects of denosumab? We have skin infection leading to hospitalization, which is uncommon. Hypocalcemia is a rare side effect. We have eczema, predominantly dermatitis and allergic dermatitis, pain in the extremities, osteonecrosis of the jaw, as was mentioned in the bisphosphonate group, and atypical femoral fracture. We might have multiple vertebral fracture following the discontinuation of denosumab, so we shouldn't stop it suddenly. We need to shift it to another anti-osteoporotic treatment. To compare about by the zoledronic acid versus denosumab adverse effect, common side effects that are similar. We have both, we can have anemia, bone pain, nausea, decreased appetite, and constipation. More hypocalcemia with denosumab, 13% compared to 6% with bisphosphonate. Calcium and vitamin D will decrease the likelihood of hypocalcemia. So you need to treat the patient with low calcium. You need to give him calcium, vitamin D before starting any of these treatment. Osteonecrosis of the jaw, the incidence it's very low, 2% with denosumab and 1% with zoledronic acid. So it's better to clear your patient, make him do whatever he needs in his dental process before starting any of these treatment. Although the ADA, the American Dental Association, sees this risk as very low, and they advise to continue treatment even when doing this procedure. But for our patient, we prefer to finish their dental workup and clear them before starting our medications. Acute phase reaction is more with zoledronic acid, 18% versus denosumab, 8%. So how long should the patients be treated? For oral bisphosphonate, consider holiday after 5 years of stability in moderate risk patients, and after 10 years in high risk patients. For the oral preparation, so we'll give 5 years for low risk patient, then drug holiday for 2 years. If the patient is still in high risk, then we move to treat him for 10 years. For IV treatment, i.e. zoledronic acid, consider a drug holiday after 3 years. in moderate risk patients, and after 6 years in high risk patients. Drug holiday is not recommended with denosumab. So we covered the high risk patient, the anti-resorptive agent, alendronate, zoledronic acid, and denosumab. And we mentioned the treatment time for all 3 medications. So how to follow the patient? As Dr. Tamer mentioned, we repeat DEXA after 2 years on the same machine, and if possible with the same technologist. Monitor at lumbar spine, total hip, and compare BMD, not T-score, because T-score is just a standard deviation. For treatment assessment, treatment failure when we have decline in BMD or more than 1 fragility fracture. So in this case, we need to rule out non-adherence and scan issues and secondary causes for osteoporosis, including medications. Treatment success, either if we have stable or increased BMD. So even if the BMD is stable, it's treatment success in this case, and absence of fragility fracture. So always compare the BMD, not the T-score. Scans area should be similar. The measured area should be comparable. Watch for improper positioning, incorrect scan analysis, and artifact like fracture and degenerative changes. Thank you, everybody, for listening.
Good evening, everyone, and thank you for joining us tonight. I will be presenting the last part of our webinar tonight, and that's the Kuwait clinical guidelines for the management of steroid-induced osteoporosis. And after that, we're going to have the Q&A session. Steroids are a valuable group of drugs that have been used for their potent immunomodulatory effect. They were discovered in the 1930s, and that was the beginning of the era of the steroid therapy. And their synthetic derivatives, they were discovered in the 1940s. Although their use was limited initially because of the high cost, but as they became more affordable, they were used for various conditions, inflammatory and autoimmune conditions, but their chronic prescription was limited because of the possible complications. These complications may include diabetes, resistance to infection, delayed wound healing, gastritis, cataract, psychosis, avascular necrosis, and osteoporosis. The steroid-induced osteoporosis is the commonest cause of secondary osteoporosis. The global prevalence of fracture in patients on a chronic use of steroids is around 30 to 50%. At the initiation of the therapy, there is a rapid but transient increase in the bone resorption accompanied by reduced of the bone formation. This alteration in the bone remodeling happens in the first 3 to 6 months. After that, it is steroid dose and duration related. There have been many mechanisms implicated for the steroid-induced osteoporosis that you are all aware of. But in 2010, Weinstein have proposed a new mechanism by which the steroid can affect the bone, and that is the effect on the bone vasculature. Steroids can cause an early increase in the osteoblast and osteocyte apoptosis, leading to a decreased biosynthesis of angiogenic factor and a decrease in the lacunal, canalicular, and blood vessel fluid volume, and also a reduction in the water volume of the bone, diminished in the bone strength, and eventually leading to an early increased risk of fracture. Is there a safe dose of steroids? Actually, there have been many hypotheses and many talks about a safe dose of steroids, but reports have shown that doses as low as 2.5 milligram of prednisolone have been reported to result in osteoporosis. And actually, even patients on physiologic glucocorticoid replacement for the Addison disease have also been reported to have lower bone density than the controls. But how long would you expect your patient to develop the osteoporosis once you start him on the steroids? The effect of the steroids on the bone happen in 2 phases. The first phase is represented by the undercurve A and B. This phase happens in the first 3 to 6 months of starting the therapy, and it happens because of the increase in the bone resorption. In this phase, there is a reduction in the bone density of around 5 to 15%. This phase is followed by the second phase, which is represented by the undercurve C. In this phase, there is a progressive and sustained bone density loss of 2%. And this phase happens mainly because of the reduction in the bone formation. Unfortunately, there have been recent reports to show that actually the steroid effect on the bone and the process of osteoporosis happens even before 3 months. According to a cohort study of more than 1.5 million adults that was published in the BMJ in 2017, within 30 days of initiating the steroids, even at relatively low doses, users had nearly 2-fold increased risk for fracture, 3-fold increased risk for venous thromboembolism, and 5-fold increased risk for sepsis. Although half of these patients were prescribed only 6-day pre-packed methylprednisolone dose pack, which was only a tapering dose, small dose of steroids. The increased risk persisted at prednisolone equivalent doses of less than 20 milligrams per day, and they concluded that greater attention to initiating prescriptions of these drugs and monitoring for adverse events may potentially improve the patient's safety. Because of the greater morbidity of the steroid-induced osteoporosis, international organizations have set their own guidelines to treat the steroid-induced osteoporosis. Initially, these guidelines were BMD-based, but reports have shown that there is a mismatch between the BMD results and the prevalence of fracture in patients on steroids. Actually, they found that patients on chronic use of steroids tend to fracture at a higher BMD than expected. The steroids as a risk factor for fracture independent of the BMD result can be because of many factors or mechanisms. One of these may be the effect of the adverse effect of the steroid on the muscles, leading to increased tendency to fall. And another possible mechanism is the steroid alteration in the bone quality, which cannot be detected by the BMD. In a cross-sectional study of 30 postmenopausal women who had received oral steroids for longer than 3 months, and despite similar BMD values to 60 control subjects, significantly lower total cortical and trabecular volumetric BMD, thinner cortices, increased trabecular separation, and reduced trabecular number were reported in the radius and the tibia. The whole bone stiffness assessed using finite element analysis was also significantly reduced in comparison to the controls. And in 64 postmenopausal women who had taken prednisolone in a dose of more than 5 milligrams daily for more than 3 months, the trabecular bone score, which is an indirect index of the trabecular bone that you can obtain from the DIXA scan, it can give a predictive value for the fracture risk independent of the BMD. So the trabecular bone score was significantly lower than in a group of non-steroid treated controls, although the lumbar spine BMD T-score were not significantly different. For these reasons that the BMD was not giving or was giving inaccurate, we may say inaccurate results in the group of patients who are being treated on a chronic use of steroids, FRAX was suggested as a better monitoring assessment tool for the fracture risk. And accordingly, all the national organizations have updated their guidelines to replace the BMD with the FRAX score. But there are limitations for using FRAX score for assessing the fracture risk in patients on steroids. One of these is the glucocorticoid entry. The glucocorticoid entry into the FRAX tool variable is in the form of yes or no, as Dr. Nadia mentioned. So in this, you cannot, there is no detailed dose or duration for your for the steroid that you are entering, it is assuming that your patient is currently taking a steroid or has been taking a steroid in the past for more than 3 months for a dose of more than 5 milligram. So that can lead to either overestimation of the patient who are actually taking a dose less than 5 milligram, or even it can underestimate the patient who are taking much higher doses than this or being on more than 3 months on the steroids. Another limitation of the FRAX is that the predictive value of FRAX has been mainly validated for the non-vertebral fracture, while the main effect of the steroid on the bone is on the trabecular bone, represented by the vertebral fracture. There has been many proposals to adjust for this limitation in the steroids in the FRAX tool. Maybe the easiest one of them is Canis, and a simplified version of that was included in the Kuwaiti guidelines. So using the Canis guideline, you can adjust the dose of the steroid for your patient, the risk fracture. Actually, you can adjust both of them, the hip fracture risk and the major osteoporotic fracture risk, according to the dose and the age of the patient. For example, if your patient is taking a dose of 2.5 to 7.5, then you don't need any adjustments because this is the default dose that is entered into the FRAX tool. If your patient is taking a dose less than 2.5, then you have to subtract from the fracture risk calculated because your patient calculated fracture risk is overestimated. If your patient prednisolone dose is more than 7.5 milligram, then you have to add to the calculated fracture risk that you obtained because the fracture risk for these patients were actually underestimated. The first version of the Kuwait clinical guidelines for the management of steroid-induced osteoporosis was in 2015. These guidelines are being periodically updated according to the recent clinical evidence data. So today I'm going to discuss the most recent 2022 version of the Kuwaiti guidelines for the treatment of steroid-induced osteoporosis. This new guideline is FRAX based, and remember that FRAX is not validated for patients under the age of 40 years old. In such group less than 40, you still have to use the BMD to assess the fracture risk. The management of steroid-induced osteoporosis starts with the initial evaluation. These were discussed in detail by Dr. Thamer, so I'll just go through them very quickly. The initial evaluation starts with the history and physical examination, height and weight measurement, lab tests including CBC, ESR, RFT, LFT, mineral profile, alkaline phosphatase, parathyroid, thyroid, and vitamin D. And you may use additional tests like gonadal hormones, celiac screen, 24-hour urine for calcium, sodium, and creatinine. And then you can proceed with the general measures to reduce the risk of osteoporosis. These include reducing the dose or change the route of steroid when possible and consider steroid-sparing therapy. Measures to reduce the risk of falls, smoking and alcohol cessation, and limitation of the caffeine intake. Weight-bearing exercises, treat the vitamin D deficiency if present, and maintain the calcium intake of 1,000 to 1,200 milligrams per day, preferably through diet. The guidelines are of two parts. The first part is discussing the management of steroid-induced osteoporosis in postmenopausal women and men above the age of 50. And the second part talks about the management in premenopausal women and men younger than 50. So I will start by discussing the guidelines of postmenopausal women and men above the age of 50. This guideline depends on the duration of the steroids therapy, if the treatment is more than 3 months or if the treatment of steroid is less than 3 months. If your patient's steroid therapy is more or equal than 3 months and he's having any of the risk factors of history of fragility fracture, represented by spine, hip, or more than 2 other fractures, or if the fracts above upper assessment threshold, or if the intended dose equivalent to steroid is more or equal to 7.5 milligram per day, or if the patient was older than 70, then you follow the red recommendations and you treat the patient accordingly with the alendronate, zoledronic acid, denosumab, or teriparatide. If your patient is having none of these risk factors, but still his fracts is above the intervention threshold, again, you have to treat the patient using alendronate, zoledronic acid, and denosumab. If your patient is having none of these risk factors and his fracts is not above the intervention threshold, then there is no need for any active management. Just refer him to the general guidelines to reduce his risk of developing osteoporosis. If your patient's treatment of steroid is less than 3 months, and he's having any risk factor of history of fragility fracture, or he's older than 70, then again, you follow the red line and you treat the patient accordingly with the same treatment, alendronate, zoledronic acid, denosumab, and teriparatide. And if the patient is having none of these risk factors, then just refer him again to the general guidelines. That was simply the guidelines for the postmenopausal women and men above the age of 50. Now, talking about the guidelines for treating women, adults, women more than 18 years, which are pre-menopausal women and men younger than 50 and on steroid therapy for more or equal than 3 months. This guideline is also of 2 parts, depending if your patient is younger than 40 or older than 40. If your patient is younger than 40 and he's having any of these risk factors, history of fragility fracture, Z-score less than -3 at the hip or spine, you can see here that we have used the Z-score because the patient is younger than 40, and as I mentioned that fracts is not validated for patients then younger than 40, so you have to use the BMD in this point. So if the Z-score is less than -3 at the hip or the spine, or the more than 10% per year BMD loss at the hip or spine, or he's on very high dose of steroid, defined as steroid more than 30 milligram per day and a cumulative dose of more than 5 grams in the past year. If he's having any of these risk factors and the woman with childbearing potential not planning for pregnancy during the treatment period, then do a DEXA scan if not done, and then treatment is recommended with alendronate, denosumab, and teriparatide. If the patient is having none of these risk factors, so you just need to monitor with a DEXA scan every 2 to 3 years, depending on the risk factors. If your patient is older than 40 and he's having any of the below risk factors, history of fragility fracture, fracts 10 years risk for major osteoporotic fracture more than intervention threshold, or on very high dose of steroid, again, the woman with childbearing potential and not planning pregnancy, then again, do the DEXA scan and treatment is recommended accordingly. And if the patient is having none of these risk factors, then you just need to monitor the patient with the fracts and DEXA scan every 2 to 3 years, depending on the risk factors. We have follow-up measures for patients on chronic use of steroids. You have to measure the DEXA scan at the initiation of the steroid use and after 1 year. If the BMD is stable or improved, then measure the DEXA scan every 2 to 3 years. The height measurement every 6 to 12 months with prospective height loss of more than 2 centimeters, consider vertebral fracture assessment or plain X-ray. Vitamin D measurement every 6 to 12 months, assessment for new fractures in the ribs and vertebra, and active pharmacological treatment should be continued until no further exposure to steroids. The last point that I want to talk about is steroid-induced osteoporosis reversible. Steroid effects on the bone appear to be generally reversible, and once therapy is stopped, bone repair occurs over the year following drug cessation. Thus, if feasible, steroid cessation may be the therapy of choice for the steroid-induced osteoporosis. And thank you for your attention. Please don't forget to write your questions in the Q&A chat. Thank you.
I'd like to thank all the speakers. Then thank you, Dr. Thamer. Thank you, Dr. Shema, and thank you, Dr. Fatma. And now we are ready, the four of us, to answer your questions. Some we have received in the chat. So who would like to start? Thamer, you have any questions?
Okay, so
Answer.
we can start. Yeah, sure. Let me start reading the questions. We got first question about for pregnant women, what is the recommended type and dose of vitamin D and calcium? Now, the guideline doesn't really specify very exclusive levels for vitamin D and calcium. They did, however, mention that they need to maintain a normal vitamin D level. And that's not really for the issue of osteoporosis, but mainly for perinatal and antenatal care. So vitamin D sufficiency would be somewhere between 75 and 150. So far, it seems like the doses of vitamin D used, whether is it the 50,000 or the 5,000 or 1,000, seems to be safe during pregnancy. Calcium supplementation is, as well as in non-pregnant women, is considered to be safe if it's given at the right appropriate replacement dose.
I have a few of questions that I can answer quickly. How to assess the pediatric group? Actually, none of us is a pediatrician, so we'll restore this for the pediatric endocrinologist. We are not talking about pediatrics in our webinar today. If there is a surgical procedure to the one of the vertebral spine, how to avoid a mistaken results? That would be easy. We have 4 lumbar spines for evaluation, and you can eliminate 1 or 2 where you have the surgical procedure. But if you have all of them, we need the femur neck for assessment of fracts, and you can use the distal 1/3 of the radius if you need that. One quick question: what is the definition of recent fracture? Any fracture 2 years in the last 2 years at the time they present to you. And why TBS is not included in the Kuwait guidelines? Simply because it's not included in our machines yet. It's a simple software. I hope we can get it in the near future. And a quick question: does fracts without BMD underestimate the risk of fracture? Of course, to have a fracts with a BMD, that will give you a more accurate and a more precise risk of fracture. But many cases, when you fract the patient without the BMD and he is below the lower assessment threshold, you can save them from having an unnecessarily BMD DEXA scan. Last but not least in my list is, what is the risk of not treating a non-vertebral, non-hip fracture? If you have one non-vertebral, non-hip fracture, you fract these patients and look at their fracture score. You have also to include a VFA, because a one fracture is a risk factor for a second fracture. So this patient might have just a morphometric fracture in the vertebral spine, and that will upgrade him to a very high risk patient. So sometimes we don't have to treat them if they just have a non-vertebral fracture and the fracture score is below the intervention threshold. But you have to bear in mind that VFA is indicated in such patients. So I'll leave the...
Dr. Nadia, if you allow me, I have a question to Dr.
Sure.
Thamer. Thamer, you have presented a diagram of comparison between the teriparatide and the ROMO. And there was a significant difference in the effect on the BMD and the improvement and everything. So would that change your clinical practice with your patient? I mean, if you have a patient with no risk factors, no cardiovascular risk factors, and they are high risk for a fracture, would you start all of them now after this data? Would you start them on ROMO instead of the teriparatide, or would you still use the teriparatide as our maybe clinical experience is still limited with the ROMO?
So thank you for this question. So the successful part of any therapy, I mean, talking about specifically osteoporosis here, we know that BMD is a surrogate for bone health or bone density and improving the risk of a fracture. But to determine the effect, we need a fracture risk reduction values between them, and that's still lacking. The data that I presented was only BMD increase and some suppression of bone turnover, but we don't have a solid evidence of reduction of risk of fracture, which is the ultimate goal that we want when we start with these patients. So I think they're both available. They're both good experience, and of course, teriparatide, we're still getting experience with the bromo. Either one would be a good, valid way of doing or improving the outcome for reducing risk of fractures.
And I feel also the method and the frequency of drug administration does make a difference. Many patients, they don't prefer a daily injection.
Exactly.
Whereas if it's a monthly injection, provided these patients are not at a high risk of cardiovascular and they were not, they did not have any event during the last 1 year.
Actually, I have many patients who are supposed to have the teriparatide, but they are refusing because it's annoying daily injection.
Yes, true. But unfortunately, also, it's not yet approved for glucocorticoid-induced osteoporosis. Hopefully in the future, the romosozumab. Any more questions?
Yes, I have a question here. What medication preferred for patients with breast malignancy and renal failure patients? So for malignancy, we prefer selective estrogen receptor modulators, the serums, which is like raloxifene, 60 milligram OD. It decreases the risk of vertebral fracture in these patients. And for renal impairment, we prefer to use denosumab, which is Prolia, for creatine clearance below 35.
I have a question about the steroid therapy. Does the steroid treatment causing steroid-induced osteoporosis include inhaled steroids? Yeah, I didn't present this data, but I do have evidence and reports of the inhaled steroid, especially in the children. That kids with the bronchial asthma, they tend to have lower BMD because of the inhaled steroids. So, and direct answer to your question, yes, it does. The inhaled steroids do cause steroid-induced osteoporosis on the long term.
I do have other questions. One is, what is the explanation for patients being at very high risk for fracture after recent fracture and not an old fracture? Dr. Nadi, you want to answer this? I think this.
Sorry, I was looking into that. I didn't pay attention. I was.
These are questions sent to me directly, so
okay.
That's why you don't see them. So, any particular explanation why patients being at very high risk for fracture after a recent, but not an old fracture?
Well, the study has shown that the incidence of fracture are at maximum in the first 2 years after a sentinel fracture. So if you have a fracture today, within the coming 2 years, the number of fractures are at the highest hazard ratio. And after that, the numbers start to decline back to the baseline. So this is just what found from observational at comparing the incidence of fracture and when it does occur maximum. And it's been recognized very recently, only in the 2020, this came to our attention in management of osteoporotic fractures. So that's what we call imminent risk. Imminent means that it will happen very soon. And that was proved by many observational studies.
There's another question in my box. Can you start a patient with, he's supposedly receiving anti-resorptive therapy, and then he became high risk, meaning that while he's anti-resorptive therapy, he developed fractures, like two osteoporotic fracture. Can you shift him to anabolic therapy? Now, before even doing any shift, there is an important step here that you need to make sure is that why he developed fracture, why he's using an anti-resorptive therapy. Anti-resorptive therapy, just like Dr. Shaima showed, they're very effective in reducing risk of fractures. So if someone develops a fracture, why he's receiving therapy, any therapy, you want to investigate why this happened. So is this a failure of the drug itself, or is it compliance, or does the patient has other medical condition that preclude the therapy to be ineffective before even doing the shift? Now, considering that this patient is a failure of therapy, meaning he had all the necessary steps to receive the therapy, he's been receiving it well, he has no other medical condition, and still that therapy did not improve his risk of a fracture. He developed fracture for that. So the evidence has not really yet been conclusive whether to switch patient only on anabolic or keep them both at the same time as a combination therapy. Now, combination therapy might work in very, very small number of patients who've been developing fractures even though they are on anti-resorptive. Now, this has to be cases discussed, basis by basis cases, and making sure that actually there is no other side or issues going on with the patient that puts them at risk for further fractures. Do you have, Dr. Shema, have any questions?
Yes, I have questions here, like how can women with premature ovarian failure be assessed? As you know, a woman with premature ovarian failure is ovarian failure like before the age of 45. So we start by history examination, doing the routine test, and we can track the woman and see her risk. And we follow through the guidelines. If she's high risk, we can start treatment. And there is another question, like calcium supplements are needed in all cases of osteoporosis. As Dr. Thamer mentioned, it's not needed. If the patient, usually we have a booklet for the calcium food, and the patient can calculate how much calcium they intake every day according to the value needed. If the patient taking enough calcium, no need for supplements, as mentioned by Dr. Thamer. If the patient is not taking enough calcium, then we go for supplement. Another question, is magnesium mandatory when we give calcium to the patient? It is not mandatory. We check for magnesium. If it is low, we treat the patient with magnesium. If it is normal, no need to treat this patient. And the next question is how long will be the drug holiday for each treatment? As we mentioned for denosumab, it's not advised to have drug treatment, but once you stop it, you shift to another treatment. And for zoledronic acid and andronate, it's advised to have 2 years treatment, drug holiday. And of course, we assess the patient. If he's high risk, we can continue for longer duration. The last question is your treatment decision going to be different? Patient going to spinal surgery, or the algorithm is going to be the same? I think this is more Dr. Thamer, including your part, is more goes with anabolic treatment.
So if the question is your treatment decision going to be different, the patient going for spine surgery? So define a spine surgery, what does it mean? So if it needs someone who developed a vertebral fracture and he's going for a kyphoplasty or vertebroplasty, then this patient belongs to the group, as Dr. Nadia mentioned, very high-risk individuals who developed a fracture and they prefer to be on anabolic therapy. So that would be the algorithm of the guidelines what they take you to. I do have other questions. There was one question, easy one. After 12 months of romosozumab, which drug can be add on or no drug at all? We said all anabolic therapies, they require to be on anti-resorptive following the time spent on the anabolic agent. So 2 years of teriparatide and 1 year of romosozumab, this has to be followed by anti-resorptive therapy. Another question, do you give teriparatide after hip fracture? We know there can be transient BMD loss in the hip with teriparatide. That's true. There might be some decline in the BMD initially, but we've seen it in patients who are switched from an anti-resorptive to a teriparatide. You will see a small drop in the BMD at the femur, but not in patients who did not receive therapy before. So that's the difference between the values. Now, we prefer in patients with hip fracture to be given zoledronic acid. We think there is a mortality benefit if it's given within the first 90 days.
Can I have a question for Dr. Shaima? You have mentioned about the dental surgery and stopping the drugs before the dental surgery, because I get many questions about this issue. So how long do you advise the patient to stop either the zoledronic acid or the denosumab before going to any dental surgery if he did not clear up before starting the medication?
Dr. Nadia, it's mentioned by the ADA, American Dentist Association, that still with treatment you can, but in our real practice, we stop it like for 6 months and then we send the patient. I don't know about Dr. Nadia and Dr. Thamer.
Well, it depends also on the dental procedure. I mean, if it's an extensive one or just a simple thing. Dental extraction might carry a risk, but sometimes not all dental procedures are the same. And there is a table, I think Dr. Tamer, we once presented, you remember? In each dental procedure, what is the policy to be taken up? But what I feel, all the dentists are now scared when the patient is anti-resorptive. That is not really the case, and there is an exaggeration in the risk in that.
Yeah, because I had a patient on denosumab who needed dental procedure, and I mentioned in my letter to the dentist that it's a very low risk. You may carry on with your procedure, but he totally refused.
Usually when patients who received mega doses, such as cancer patients, it's been noted. And we always advise, of course, them for about oral hygiene, because that can add on to the problem. In my list, I think you answered all questions.
There's a question sent here. Is calcium supplements not from food related to MI or renal stones? No, I mean, dietary calcium from diet has not been linked to increased atherosclerosis, neither increased risk of renal stones. And actually, a patient with renal stone is not advised to consume less calcium. So that's for the supplements. How effective is FRAX in risk stratification of patients with chronic liver disease, Dr. Nadia?
Chronic liver disease would be included under secondary causes of osteoporosis. Those patients might be vitamin D deficient, so please pay attention to that as the base of your treatment. And FRAX, you can still use it, and use your clinical sense also with that. They are at high risk, they have secondary causes, and vitamin D deficiency is quite common. Tamer, you are seeing a lot of these patients with the transplant.
Yes, we in Jaber Hospital, we run a chronic liver disease and liver transplant clinic, and we see a lot of patients who have very low bone density. And actually, to be honest, these patients, just to look at their bone density and the risk for, and also the incidence of their fractures, they don't even need a FRAX because their bone density is very, very poor, and they already had the fractures. And these patients, they go on therapy even without doing even a FRAX for them. Another continuation of the question, Dr. Nadia, is about the Q fracture. It's another algorithm for calculating risk for fracture. Is it possible to use it for predicting fracture instead of FRAX?
Well, I think FRAX is more widely used than this. This one takes into account other risk factors more extensively than the FRAX, but FRAX is internationally accepted, so I think we'll stick to the FRAX for the moment.
Plus, the country model is also a rate limiting factor for evaluating, and Q fracture does not really accommodate for the change in the population, but FRAX do, because it's based and linked to the risk for hip fractures in Kuwait. I don't have any more questions sent to me. Anybody else have any questions?
No, I think we've covered, and yeah, my books, I don't see any more questions that has not been answered. Anyway, I think we're coming to the end of this webinar. I'd like to thank all the attendees, of course, thank all the Kuwait Osteoporosis members who have participated. This is our first step in launching our guidelines. Definitely we'll have more lectures in the future to get these guidelines widely spread among the doctors in Kuwait and in the Gulf area, I hope. So thank you very much, and hope to meet you again, and I hope you benefited from the information presented today. Thank you again.
Thank you so much.